So the photon counting CAT scan is mostly for ischemia. And the photon counting CAT scan I would order just and if you are suspecting any sort of ischemic when somebody has symptoms of shortness of breath, chest pain, decreased exercise tolerance. Is that
And would you do that then before you would do a cath or?
yes, yes.
Uh-oh.
If you can identify areas that are not getting enough blood flow, when it's compared from rest to stress, like in a stressful situation, if you notice that that area of the heart is not getting enough blood flow, then that would lead to a positive CT, which would then lead you to do a cardiac catheterization, a more invasive procedure.
Okay. And then my last question would be, can you do any other valves besides the aortic valve with the same technique as a TAVR?
Yeah, that's an interesting question. I wonder if I have a slide on that for visualization purposes. I don't have the visual, but we are doing you can actually work on all the valves. As of right now, Edwards just, and I have no stock in Edwards. I know I keep saying their name, but they just came out with a procedure where you can do a total mitral valve replacement with one of their valves as well. So it'd be your mitral valve, as well as I've seen the pulmonic valve have a complete valve replacement as well. As far as a tricuspid, Edwards also just came out with a total tricuspid valve replacement as well. It's called the Evoke device. So as of right now, all four valves can be replaced through a transcatheter approach. Although we have not adapted completely, or we haven't even done one of the tricuspid or the mitral yet. Um, there are some large centers that are doing that across the country with their own risks and benefits. Yeah. Mhm.
Doctor, thanks for coming.
Thank you.
Could you give us a feel for you as a TAVR doctor or the TAVR approach that says they should be going to cardiac rehab after the procedure at some point? And what are that benefits to that TAVR person going to cardiac rehab?
Yeah. So the question is, what are the benefits and should patients be going to cardiac rehab after an aortic valve replacement? I'm a very strong believer in cardiac rehab. I tell all my patients they should go to cardiac rehab. In fact, I've never had a patient come out of cardiac rehab saying, "Wow, I wish I wouldn't have gone to cardiac rehab." Every one of my patients has had a very positive experience with cardiac rehab. In fact, I know you asked about valves, but just to put this in there, it is a class 1 indication from American College of Cardiology to go to cardiac rehab after a stent is placed. And they say it's just as important as getting the stent itself. Why does that matter so much? Cardiac rehab is kind of a multifaceted approach where, yes, you do your exercises, but yes, there's also a lot of teaching that sometimes we don't always get to in office visits, teaching about medications, teaching about nutrition, and teaching about several other topics. I think we even have cooking classes in our cardiac rehab. So these are all things that you and I probably would not talk about cooking classes because I don't cook, but in our office visits. So having this multifaceted approach towards your heart, even after a TAVR, so it also has education about your TAVR and your aortic valve replacements in cardiac rehab. So definitely recommend it and have never had negative um, comments about it. Mhm. And the way I also describe it is you're getting a new engine, right? But with your valve, the frame is still the same. Like you're getting a new engine to your car, but the frame has slowed down because that's what the aortic valve does. The aortic valve slows you down over time. People don't notice their symptoms, but they're also doing a lot less. So now all of a sudden you've gotten this new engine, but you still need the rehab to get your frame caught up with your engine, if that makes sense, just because of deconditioning. That's a aortic valve is a kind of a smoldering disease that kind of causes you to become deconditioned.
Hi, this is my first meeting here. I had bypass surgery in December, and prior to my heart attack, I was monitoring my blood work, my lipids, and I had periodic stress tests that kind of revealed nothing. I'm in cardiac rehab right now, and I love it, and it's great. It's a wonderful experience. I'd love to know moving forward, what's the best monitoring I can do. I had a stress test a year ago that revealed nothing. Right up until, in the emergency room, my EKG was normal. So finding out that I was going to have a triple bypass was a real shock to me when it occurred. And I just want to keep the arteries I have now as healthy as possible.
Oh, that's a great question. And it is a question that commonly comes up in the office is how often should we do some type of non-invasive monitoring after you've had a cardiac event, including a bypass surgery, which this gentleman has had in December of 2025. And his question now is, I've had negative stress tests. All my non-invasive tests have come up pretty negative. And so what sense would it be to order these non-invasive tests if they've kind of had false negatives in the past? What should we do to monitor that? And my follow-up question to you, and this is my question to patients in the room as well, is what type of symptoms were you having before you had your bypass? Or what bought you the stress test? Mhm. So this is a great example of not having your typical symptoms. He's saying that he basically had some shortness of breath, and he's very high functioning, was running and and bicycling, and noted to have some shortness of breath. And how is that going now as far as the breathing? So when I these stress tests, when I feel like they're not working, what always works is a history on the patient and talking to the patient and making sure that what were your symptoms before your bypass, and will those, if those symptoms arise again, then that kind of is the cue. Like you should have a regular follow-up, every 6 months or so with a cardiologist, and based off that, and your symptoms that you're having as far as that shortness of breath is kind of your cue, not necessarily chest pain or jaw pain or things that you kind of see on these slides sometimes about what typical chest pain or typical angina is involves. So if you were to get this shortness of breath in short, then you would have to decide a next test, and that next test could be a stress test. Or if you feel like the stress tests haven't worked in the past, I would want to look back on your stress test, because there are things called balanced ischemia on stress tests where it shows up negative. But the thing with the stress test is, especially our nuclear stress test, it only shows relativity. It shows, is this area not getting enough blood flow as compared to another area of your heart? But in your situation, it could have been that all the areas of your heart were not getting enough blood flow. Yeah, so that sounds like six block arteries, kind of sounds like you were not getting blood flow to all the areas of your heart, in which case that sometimes shows up on a stress test as a false normal or a false negative stress test, because of the fact that you don't see that relativity. You don't see one side not getting enough blood flow because they're all not getting enough blood flow. Does that make sense? Now, the normal EKG is just that EKGs are good for that 6 second period that if you're not having chest pain in that 6 second period, sometimes they won't give you enough information as to whether or not you're not having enough blood flow to that area of your heart in that moment. So EKGs are good at kind of predicting whether or not you've had a heart attack in the past, but everything always comes back to the history. And your history for you, individualized, would be that shortness of breath. And if stress tests don't work out for you, there's other things that we kind of talked about, coronary CTAs. You could do a CAT scan, which gives you 100 milliliters of contrast into your IV, and then they could watch that contrast as it goes through your bypass grafts to see if that's open or not. That is one way of non-invasively doing a test. If we feel that that is not accurate enough, or if you feel that there's something that's not showing on that, then you would end up in the cath lab with myself or one of my other three colleagues that also do these procedures. Do I think that's appropriate surveillance? No, I don't think you should be getting a cardiac catheterization every 2 to 3 years. I think what the approach is, and usually most of our colleagues say this as well, is listen to the patient, decide what the next appropriate stress test or CAT scan is for the patient, and then if need be, or if the symptoms persist despite negative testing, then end up on the cath lab table. Calcium scoring is a risk stratification. So the question was, what about calcium scoring in a patient that's had a bypass? Remember, calcium scoring is more so for risk stratification to somebody that has not had a cardiac event yet. So it's for somebody that just has hypertension and risk factors, and you're deciding whether or not how aggressive do we want to be with this patient with that calcium scoring? And that calcium scoring can bump you up to a little more aggressive, or it can say, oh, well, my calcium score is 0. We can back off a little bit with my intermediate risk category that I'm in right now. But you're already in the highest risk category, so it wouldn't change anything for you. If you would be treated as the highest risk with the lowest goal of LDL on your lipid score.
Hello, my name is Judy Marks. I have 2 questions. Surgery for me in 2024, and I was happy that he was able to do that. I have a question though about B vitamins. My doctor originally described some tablets for B12, and I don't know if that's necessary for heart to take B vitamins. And then I discovered there was such a thing as injections, B injections. And I don't know what's the difference between the two, and with a person who's had stents, would the vitamins be better than the injections? Or how do you determine whether the heart patient needs B12? And then I have another question after that.
Okay, sounds good. So I'll repeat those questions for the online audience. So Judy had some stents back in 2024. Her primary care physician stated that her vitamin B12 was low and decided to put her on oral versus injections. And the question is, how do we decide that B12 helps with your heart, and which one is the better one to take, intramuscular versus oral? Am I right when I
Yeah,
asked that?
do you really need it?
Yeah, so I don't necessarily think that they started it for your heart. It may have some energy. It might help you with energy and indirectly help with your exercise activity, but I don't routinely check B12. It's a little bit I consider it a little bit out of the cardiology world. However, when I did do internal medicine, I remember if you had a low B12, I think we would start off with injections. It's been a while, sorry. And then move on to oral if need be for maintenance therapy if you continue to have that. But in the beginning, I think if it was low enough, you would do a B12. As far as relation to your heart, I know that vitamin B12 deficiency can cause some heart problems, but I don't know if there is a direct correlation with supplementing your vitamin B12 and cardiovascular benefits, or a decrease in cardiovascular events or neurological events with that. Does that make sense? Like, it doesn't decrease heart attacks in the future, but if you don't have enough B12, you can have an issue with something called heart failure. Does that make
If
sense?
it caused you to have heart failure?
No, I don't think it would cause you to have it. And when I talk about heart failure, I do have a slide on it. It's a very ominous term. However, all it really means is the heart is not pumping enough to meet the body's needs.
Okay.
But no, I don't think having low B12, or I don't think you would have a heart failure from moderately low B12. And I don't necessarily think your PCP was thinking on a cardiology standpoint. I think they were just helping you out on your vitamin B12 deficiency.
I have one other question though, and it regards to a skin disease that I have called bullous pemphigoid. Do you know anything about that and how it's related to the heart, and if it is effective to the heart?
Well, the one thing that those skin diseases do is they cause increased inflammation, and inflammation in the heart is a very hot topic these days. You do want to keep your inflammation low. As far as bullous pemphigoid and what do I know about the etiology and how to cure it, how to treat it, I don't. But I know that increased inflammation can cause problems, as well as increased cortisol levels. And the thing in the Midwest was in the mornings when your cortisol levels are the highest, and if you're out there shoveling snow, that was a very increased incidence of heart attack. So it has this correlation.
I do know I was originally on cortisoids, and they recently put me on Dupixent, which has been like a miracle drug, I think, because it really decreased the itching substantially. And I just wondered if you mentioned cortisoids, and they do affect the heart. But I wonder what you know about Dupixent as a biologic with the heart, Dupixent and heart. that medicine with a skin disease that might affect the heart?
I think you just watch out for tachyarrhythmias, which is just a fast heart rhythm, and you just kind of keep your regular appointments with your cardiologist, and they'll just kind of follow along. But the question was, is Dupixent for bullous pemphigoid okay, and what side effects does it have on the heart? And the main thing was the answer to that is just keep your 6-month follow-up appointments, look for any symptoms of heart failure, which it does not cause, or tachyarrhythmias, which it can cause, which is just fast heart rhythms. It's just things to look out for. And I meant the cortisol is a hormone that is released in the morning. The corticosteroids that you take are actually things that you take to decrease your inflammation for your bullous pemphigoid. So
Difference.
yeah, sorry. I think I may have, they kind of sound the
The
same.
first one you mentioned, what is?
Cortisol is just, it causes more stress and inflammation in the mornings, and corticosteroids decrease inflammation. For your bullous pemphigoid, I think you were on that. That's what I think you were describing. Yeah. Mhm.
Good morning, doctor. Thank you for your expertise and for your presence. I would like to come back to the prevention. Earlier, we were talking about that. So, for instance, if the stress test was okay, and if the echocardio, the echocardio was okay too,
Yeah.
is it possible that one of the arteries can be still blocked? And unfortunately, apparently the only way to see that it's to use, even 2026, to use a highly carcinogene procedure, which is a CT plus the radioactive in your vein, basically in your the IV.
Yes.
How come? Is it true? I read, so I don't know if it's true, but there is an MRI which is basically non-carcinogene. So this is the balance. Is it as a prevention? Because basically it's like a mammogram. I heard that, every year ladies go to mammogram, but there's a risk because they use highly carcinogen radiation or CT scan to see. So to prevent the cancer, but in the meantime, it gives you cancer. So do you, for instance, in heart heart domain, is it true that there is another way to see if there is a coronary issues?
I understand your question. I think the question is getting a CTA calcium score and angiogram, basically a coronary CTA on when your stress test is negative. What is the cost and the risks and benefits of getting a CAT scan for preventative purposes when the CAT scan itself can give you radiation as well as contrast that can affect your kidneys? And is there another test that you could do for preventative ways without getting the radiation and the contrast? So, and I think you alluded to kind of a cardiac MRI.
Yes, I heard that. So
yeah, so a cardiac MRI is useful. You would still be using gadolinium as well as so by doing that, yes, you decrease your radiation.
But gadolinium
but
is
you also against your kidneys, it's kind of, if you have a chronic kidney disease, it is a risk. If not slightly more risk than contrast, depending on what they're using as far as which type of gadolinium and how concentrated it is.
Yes.
So yeah, you're kind of at a catch-22. What do you do? And at the end of the day, it's kind of what we discussed is that we listen to the patient and listen to symptoms. And if the symptoms persist, then you go on to the next test and you decide how invasive do we need to be, and at what point is this test more beneficial to the patient than it is to just follow back in 6 months and because of a negative stress test. Because that is the question at hand, right? We get these negative stress tests and we have persistent symptoms, and maybe we don't believe these negative stress tests. And some of us sometimes don't believe the stress tests either. And I've had a handful of patients just in the past 2 months where we get the negative stress test, persistent symptoms, and we have to make a decision on what to do, a CAT scan versus a slightly more invasive with me with a coronary angiogram. And what I've seen a lot of my partners doing is doing the CAT scan first and then deciding whether or not we can not do the invasive procedure with myself.
If the echocardiogram reveals that, let's say 61% of the flow, that means if an artery or any coronary vessel can be still blocked and it can still be blocked.
That's a great question, and one that's overlooked quite a bit. And the question is, if you have normal ejection fraction and your heart is functioning well, can you still have a blockage? And when he's talking about an echocardiogram, which is an ultrasound of your heart, if you notice on this slide here, I can actually refer to the slides, it shows how well you're pumping, the size of your chambers, and valve function in real time. Nowhere on this does it show your plumbing, right? It doesn't show your coronaries on this ultrasound. And in fact, you can have triple vessel disease. You can have all three of your vessels narrowed and still have a normal heart function. It takes quite a bit for your heart function to go down. And you could also have things called collateral flow, which is small little twigs that form and help out that side of the heart from another vessel that is helping out a vessel that is blocked. So an echocardiogram by no means is an assessment of whether or not you have coronary obstruction.
And again, because we're in the full speed, sorry, but just one.
Mhm.
Now we're in full speed of AI. Do you think now, because of your expertise, do you think in a few years or months or whatever, we can with AI detect now without using this highly carcinogene procedure? Can we or it's just it doesn't work like that way?
No, I mean, that's a good question. Can AI detect whether or not we have coronary obstruction with an echocardiogram or just, I guess, with what means? Would you say that?
I mean, not to use the CT, for instance, maybe in a few months or years, hopefully soon, we don't need the CT scan, and maybe we can use another, because it's still, for me, forgive my ignorance, but we're going to the moon. We have such, and for something very important at the heart, we're still excuse me, but we're using 20 years, 30 years procedure. That's what doesn't make sense to me. Forgive my ignorance, but like, for instance, I got an MRI and I discovered everything. So,
Yeah.
I even have this, well, whatever, that's my story. I have a 6 millimeter cyst on my pancreas. So whatever, it's maintained so far, thank God. But what I'm saying, it's still, for me, doesn't make too much sense that for something so important that a coronary, we use a very old procedure. That's what I'm saying. Thank
Yeah.
you.
No, that's a valid statement. The statement was, we are going to the moon and we're doing amazing things, yet we are using non-invasive procedures that are at best 70% accurate at detecting coronary obstruction. That is an issue. I think the coronary CTA world does help with that, although sometimes so the coronary CTAs do detect blockages, as you've seen, up to the single percentages, and that is with the help of AI, although a physician overreads it and looks over all the images. So in a sense, I think we are getting closer at a non-invasive approach. A lot of our partners do use the coronary CTA, but like you said, with the risk of radiation as well as contrast, because in these CAT scans, you get 100 milliliters of contrast. With our angiograms, and I'm not promoting angiograms or invasive procedures, but we give about 25 to 40 milliliters of contrast. Will there be a day where we use a cardiac MRI more often and to get? I think that day is approaching, and I think that would be slightly more accurate without the risk of radiation. I just don't know when, and I don't know when the AI will take over either.
Excuse me. Welcome, Dr. Sharma. Thank you for being here. I'm going to try to form a coherent question, so bear with me.
Okay.
I was diagnosed with AFib in 23, and in 24 had a TAVR procedure followed by an ablation procedure. As soon as I was diagnosed with AFib in 23, I was put on a blood thinner, which I'm still on. Excuse me. I'm curious about how is the decision made for someone to have a Watchman procedure, which I understand would be in lieu of having to depend upon blood thinners. I don't know if I'm right about that, but could you speak a minute about that and what the protocols all are for determining who is a candidate for a Watchman?
Yes, that's a great question. So the question was, she developed AFib in 2023, had an ablation procedure done, also had a TAVR, which seems to be not too related, but the ablation procedure was done. And now the question is, what is my risk of a stroke while on the Eliquis, and what are my benefits and risk ratio of undergoing a Watchman, and how do we know? So I don't have the CHADS VAS score up here. Let me just see what I have for AFib. Oh, did I pass it up? Sorry. Well, we can just talk about so it's an interesting question that you asked, just because there's been a lot of differing reports about atrial fibrillation just in the past 3 months. ACC, which is American College of Cardiology, just had a conference 2 weeks ago stating that Watchmans are good and people should have them, and they're non-inferior to blood thinners. And this is just my opinion, and there's differing opinion. You could ask 5 cardiologists and you'll get 5 different answers about Watchman procedures. There was another study that came out about 3 months ago stating that, you know what, Eliquis may be a little bit superior to Watchmans. And now there's actually another device called the Amulet. So they're doing Watchmans as well as Amulets nowadays. How are you a candidate for it? Well, you have to have a CHADS VAS score of CHADS-2 VAS score of above 2 to be a candidate, as well as a HAS-BLED score, which puts your risk of bleeding a little bit higher on the Eliquis. So in my practice, and everybody's practice is different, I am not routinely sending people that are on Eliquis or Xarelto. I also have Pradaxa up here, I think, to Watchmans or Amulets. However, if they have a bleeding issue, then that would be a good candidate to have that. And if they have hypertension, it depends on your age, hypertension, congestive heart failure, diabetes, a previous stroke, as well as vascular disease. And that vascular disease can be, and this is just a CHADS VAS score that I'm reciting, and that vascular disease can be vascular disease in your heart, in your carotids, in your legs. That'll buy you a point too. So all those things buy you 1 point of how much of a risk you are at for developing a stroke. And then what your physician usually does, they calculate that score and decide whether or not you have a large bleeding risk. And if you do, then you would be a good candidate for a Watchman or an Amulet, basically called a left atrial appendage occlusion device, whether it be one or the other. Does that kind of answer your question? Yeah. Okay.
We have another question.
Hi, Dr.
I'm
Sharma.
scared now.
Well, I have a comment and a compliment. So I had a TAVR 2 weeks ago, and everything's worked out so fine, so far so fine. And although I was like in a fog for, say, maybe the first 10, 12 days, I kind of attribute that with your advice that it's the anesthesia wearing off. And so I feel much better now about that. The compliment is, I'd like to compliment you on how reassuring you were with me as a patient, that we're going to take good care of you and everything's going to be good. And, that means a lot to someone sitting in or laying in bed, getting ready to get poked and cut up and all that kind of stuff. So, and then just a word for all of us here is, I walk into Dr. Sharma's office before my TAVR surgery, and he goes, well, I think you're ready. You're in the severe territory now. And he said, you probably should get it done before I'm gone. I go, where are you going? You just got here. And he goes, well, the earthquakes. I go, what do you mean? They were just little 4.0s. He goes, I don't understand you Californians. Until it's a big earthquake and it opens up and everybody falls in and dies, then it's a major deal. So anyway, I thought you would enjoy that comment. But Thank you very much for all your help and guidance, and I look forward to cardiac rehab. I need it.
I do have an irrational fear of earthquakes and turbulence on planes.
Yes, my name is Jim. I've had surgeries at Eisenhower. Can you all hear me all right? Is it on? Test, test? Okay.
Yeah, I can hear you.
Okay. I was fortunate to have triple bypass in 2018. And then 2 years ago, I had the TAVR. And a year ago, I had a new aorta heart valve. My question really is, what should the heart rate be? Would my heart rate go up after having those conditions versus when I was younger and it was in the high 50s, low 60s? Now it's more into the low 70s at the lowest. Is that common for an older person? And the rate goes up to 120 pretty fast, but it comes down fast.
Mhm. That's a great question. I didn't get the last part of it of what your personal history is, and if you're okay, I'm going to repeat what you said about your personal medical history. You had a open heart bypass, followed by 2 years later you had a TAVR done, and then you said 2 years ago, what did you have?
1 year ago, I had the new heart valve.
Was that the TAVR that you speak of?
No, the TAVR I had 2 years ago, the triple bypass 2018, and then I had the Watchman, the TAVR, but the valve was the last one I had, which is just about a year ago. And I noticed my heart rate is higher than it used to be, fairly athletic. My heart rate used to be quite low, but now it's running into like I said, probably the mid 70s, and it'll go up to 120 pretty fast.
Mm-hmm. I'm still not. So 2020, you had a TAVR, and then 2025, you had another valve replaced, or is it the same TAVR? Or is it the same valve?
No, TAVR's completely separate. 2 years ago, I had the TAVR. 1 year ago, I had the valve.
Which,
okay, the aortic valve, the TAVR, they're separate, right?
say that.
The TAVR is completely different than an aortic valve replacement.
No, the TAVR, that is the aortic valve replacement.
Okay. Watchman, I'm sorry. I'm
Okay.
sorry. I got you. Okay. I had the Watchman 2 years ago. And then
Watchman 2 years ago, TAVR 1 year ago.
Right.
And now the heart rates are elevated, and is that normal?
Yes. Thank you.
And did you have low heart rates before the TAVR?
Quite low. Like
Okay.
maybe mid 50s to high 50s, maybe low 60s.
Yeah. It's a bit of an intricate question. I would have to look at your EKGs. I have to figure out, is there a conduction abnormality happening, or is it just what we talked about earlier with the deconditioning and whatnot? And maybe you had slowed down before the TAVR was done. That doesn't necessarily point to your case, given that you had low heart rates beforehand. But it would be hard to say without looking over everything for you. Is it normal to develop high heart rates and heart rate variability? That is what seems like what you're having. You're having heart rate variability from 70 to 120 with just a small amount of exercise. That I would say is normal, but I would have to look at your whole chart, whether or not you have low hemoglobin or things like your thyroid. All those things affect your heart rate, not just deconditioning or your valves. But purely physiologically, should you have a high heart rate after a valve procedure? No, you should not. If that helps. There might be other reasons. Yeah. Oh, yes. Sorry. I think some of
Hello, I'm the other half of the heart valve, everything happening here. First of all, thank you. This may be a silly question, but recently I've had numerous friends, because of aging, who have had a stent. Okay. So, but all of it has happened, with the immediacy of chest pain, some of the normal things. I want to know how I can be proactive. Could I know before that happens that you need a stent, or is it always a matter of this happens and you need a stent? Is it blood tests? Is it my doctor's office visits? What determines that there's a possibility you need that before you really need it?
That's a good question. The question is, a lot of my friends have been having stents, and how do I know whether or not I need a stent, and how can I prevent that from happening? And then I think the answer to that question is regular follow-ups and a history. Again, I think it all comes down to talking to your physician about your symptoms. And those symptoms do include, and I have almost like a checklist of symptoms that I go down, and those symptoms include chest pain. They include whether or not you're having shortness of breath, whether or not you're having more fatigue. These are all things you want to kind of look out for. These are the signs when it becomes more of an emergent situation: chest pain, pressure, tightness, or squeezing lasting more than a few minutes, sudden severe shortness of breath at rest, a sudden numbness or weakness on one side of the arm. That's obviously may not be the stent, but maybe along the lines of a stroke. But pain spreading to the arm, jaw, neck, or back. But your question is more so preventative, and then yeah, way before that. So other things that we've talked about is a calcium score that can help you in this risk category and what risk to put you in. Are you low risk, borderline, intermediate, high risk? And there's a bunch of factors that go into these scores, and we can always plug in your numbers, just determine what risk category you're in, treat you depending on that risk. And if you have any of those symptoms when you speak to your physician, then the first step would be in the lines of a stress test or a CAT scan that we talked about in the past. But the most important thing is getting into a doctor, talking to them about your symptoms.
Morning, Doc.
Morning.
My name is Tom. I'm 90 years old. In 1980, I had my first open heart bypass surgery. 7 years later, I had my second bypass surgery. And 32 years ago, in 1994, I had my heart transplant.
Wow.
My question is, I was visiting with a friend just last week, and he said, well, if you have a heart attack, you're not going to have the normal symptoms of a heart attack, being you've had a transplant. Is that true?
That is correct. Most people with transplants don't have the normal symptoms. But the question is, so Tom has had a bypass surgery in 1980, had a redo bypass surgery in 1987. In 1994, he had a transplant done for his heart. And the question was, what are his signs of cardiac symptoms? Because he may not have the typical symptoms that a patient with their native heart has. And that is correct. You may not have chest pain for your heart. This would be another case of just sitting down and talking to your physician, and they will elicit the symptoms of shortness of breath, chest pain, decreased exercise tolerance, leg swelling, even something like leg swelling that needs to be looked into further with a follow-up test like an echocardiogram to make sure the pump function is okay. Leg swelling, although it is very non-specific, it's a good segue into talking to your heart doc as to what is this leg swelling coming from? Is it coming from my heart or other reasons, just gravity? I have leg swelling sometimes when I'm on my feet all day with procedures, so I always wear compression socks. But these type of symptoms that are not your ordinary symptoms, always get them checked out, and they'll decide what the next step is on evaluating your heart, your transplanted heart. Yeah,
Oh,
I
it's
can.
working. So a lot of us probably here are on statins. I'm on statins. I'm also a volunteer with Mended Hearts, and we're probably all on statins because we're all cardiac patients. But statins have come under an onslaught of attacks recently, especially on the internet, where they say statins are very damaging, not necessary. There's the foods you can eat. Unfortunately, a lot of these doctors are chiropractors that determine that, not cardiologists. So I don't take too much stock in that. But there is something called relative risk versus absolute risk. And the drug companies use relative risk to sell statins. And a lot of us don't really even recognize it when they say, well, there's a 30% in your likelihood to have, a STEMI or heart attack. We don't consider the fact that risk, not an absolute risk. I wondered if you might just give your opinion on that.
Yeah, that's a great question. I probably get asked about 10 times a day about statins in the office, and it's a very legitimate question. They do come with their own side effects of muscle pain that is very much proven. The other things about statins that aren't necessarily proven, which was the question, was cognitive impairment. There's been some studies that have small observational studies that state that statins can cause some cognitive impairment. However, there's also been small observational studies that say that Crestor 5 milligrams low dose can actually improve cognitive impairment. And most of those studies, when you use the pooled cohort analysis, they're not really separating cognitive impairment just happening organically versus the statin. So they're not powered enough to actually say that is indeed the statins that's causing the cognitive impairment. The other question, the second part of that question was relative risk versus absolute risk. And yes, many drug companies use relative risk because it sounds so much better, right? Well, you have a 50% reduction in getting a heart attack by using this statin. But that is relative risk. However, statins as well as Entresto, as well as Jardiance and Farxiga, well, are three of the classes of medications where studies were stopped early because of such an overwhelming positive influence of the statins, which rarely happens. So if a study is stopped early because of this, their absolute risk was indeed very significant and clinically significant. That is why I still am a proponent of statins, but we live in an era where there's many other options if you don't want a statin, and I don't ever want to push my patients if they feel uncomfortable on the statins. That's why I have this slide here. The statins, as you can see, do cause a very modest reduction in your LDL, 30 to 55%, and they're still the first line foundation, not only because they do decrease your LDLs, but the most other two important issues that statins address that not many people talk about is that if you do have soft plaque in your coronaries that is vulnerable to a rupture, which causes a heart attack, then these statins actually stabilize that plaque from rupture. And thus, there has been a 50% reduction in heart attacks between like 1980 and 2005 in studies because of statins alone, because they reduce that risk of rupture. Not only that, but it's also a very mild anti-inflammatory agent for the heart. So for those reasons, I am still a proponent of statins. But if you still need a little bit more reduction and you don't want to be on the highest dose of statin, because I've seen some of my patients subjectively note that their muscle cramps are worse on a Lipitor 80 instead of a Lipitor 40, then we can always try ezetimibe, which is another different medication to try to decrease your LDL, but not have the same side effects. As well, and it can have some GI side effects, but not necessarily the muscle side effects that statins have. And of course, now we have PCSK9 inhibitors, which are like Repatha and Praluent, that help out with that as well. They don't have the same plaque stabilizing abilities that statins do, but they will get that number down very fast. And they've been great for patients as well. They do have some plaque stabilization, just not as powerful as the statins. And inclisiran, which you take twice yearly, probably in 3 or 4 years, there will be an oral form of inclisiran that you can take on a daily basis. So there's new drugs that are coming out, or PO forms of these injections that are coming out and being tested right now. Eliquis is the other question that's a little different than the question that was asked that was for cholesterol. Eliquis is a blood thinner that usually prevents strokes in people with atrial fibrillation.
Well, that is it, everybody. Thank you so much for coming today. And thank you, Dr. Sharma, for your valuable insight. We appreciate you.
Thank you. Thanks for having me.